So now moving on with our scientific session, I'm honored to welcome our first speaker, Dr. Mahesh Janarthanan sir, Associate Professor in Department of Clinical Immunology and Rheumatology at Sri Ramchandra Medical College, Chennai.
Good morning to you all. This topic, vasculitis, actually is quite huge, and to tell about every sort of vasculitis in 20 minutes is quite difficult. So I have chosen a few topics from last year that would be of interest to our group. We always like to start with the Tirukural from the saint poet Thiruvalluvar. It says, Thotanai Thurum Manarkeni, Mandarku Katranai Thurum Arivu, which means the more you dig a spring, the more the water flow will be there, and the more you seek to learn, the more knowledge will flow. Thank you. So we'll start with this first slide. This was the Asian Congress of Pediatrics in 1994 in New Delhi. There was a session on pediatric vasculitis, and one of the delegates asked the chairperson, how common is Kawasaki disease in this country? And the chairperson said, this condition does not occur in India. So any guesses who this delegate was? Yes. So the delegate who put forward this question was Dr. Kawasaki himself. So before this, there were only 2 case reports from India. And now the reason why I have put this now is from this position where we said that Kawasaki disease didn't exist in India. And now we look at this publication from last year, which actually is an analysis of the various Kawasaki publications from all over the world. This included Scopus, Web of Science, PubMed Index, all these sort of journals. And you can see that the number is increasing. You can see that now India is actually number 4 in this graph. You can actually see India is number 4 in the number of publications is there. So we have come from a stage where we said the disease didn't exist in India to now we are number 4 in the world in the number of papers. And who do you think is actually in the top 5 ranked authors? You can see Dr. Surjit Singh there at number 5. This is from the journal from last year. So the most fascinating, I think, vasculitis among all would actually be Kawasaki disease, mainly from the etiology point of view. And this publication from this year, actually it sheds a lot of light into the etiology. We know that the number of cases of Kawasaki disease is increasing exponentially across the world, and from Japan in particularly. When you want to look to a specialist for some opinion, you always look to one particular person. And for us, as far as Kawasaki disease is concerned, you tend to look towards Japan. So that is where all the action is happening most of the time, though there are other collaborators from other part of the world. From what you actually see from the data from Japan, it almost looks like it could be due to a sort of respiratory pathogen that is causing the disease, but it cannot be explained by a simple thing as a respiratory pathogen. What is the evidence so far supporting respiratory spread of a Kawasaki causative agent? There were explosive epidemics in 1979, 82 and 86 in Japan that affected the entire country. And they also did a birth cohort analysis which showed increased incidence of KD in infants with an older school-age sibling in the household. For example, there's an old-age school-age sibling at home, then there was increased incidence. And there was reduced incidence of KD in infancy among firstborn children, and the disappearance of the sibling effect if the infant attended daycare. Also, some observation has been made during the COVID pandemic. There was significant reduction in the number of cases in the US and Japan, and possibly this was due to the social distancing, school closure, and so on. And also the clinical features of KD looks very much like a upper respiratory infection with the signs of inflammation from the oropharynx, with adenopathy and edema of supraglottic structures and so on. So actually this is from 1945, they have traced the number of cases in Japan, and you can see that the first thing started when there was migration of people from the other parts of the other neighboring countries especially after during the World War times, there was repatriation of Japanese soldiers from China and Korea and so on. And then there were three major epidemics again in this part of the time. That was in the 1980s, 85, and late 80s. And they were all. This all probably suggests that this could be there could be a triggering agent, and there's a susceptible population there. That is what the theory suggests. And also it has been gradually increasing, a plateauing, and then a very rapid rise after that with major peaks there. And again, you can see on the color here is for the different age groups. You can see that the less than 6 months, it's more or less static throughout. And for the maximum rise has been for the 24 to 60 month. The rapid rise in Kawasaki cases is for that age group. The same paper also mentions about the different nucleotide polymorphisms that have been studied across the world. There are nucleotide polymorphisms which actually here, which are associated with KD susceptibility. There are a number of genes here, number of nucleotide polymorphisms. Then there's some which are associated with aneurysm formation and some with IVIG resistance. But however, this is not uniform across all the races. So far only 3 have been studied, and these 3 nucleotide polymorphisms have been studied extensively, and they have been found to be uniformly affecting across all races in the world. So whatever theory you want to propose for the etiology of KD, it must be consistent with the minimum set of epidemiologic observations that have been made from Japan, and that is, KD was due to Japan following World War II. There were nationwide epidemics following the initial appearance of KD, and since 2000 there has been a greater 4-fold increase in KD with seasonal and geospatial coherence in school-age children. But the number of infant cases have remained stable over 3 decades. And the COVID pandemic also proved that the mitigation strategies that were followed were associated with 35% reduction in KD cases. Again, this is a similar graph to the previous one, showing different age groups and how the number of cases have increased over the number of years. And obviously the less than 6 months being almost static throughout, with the other age groups showing phenomenal increase. They have adjusted these rates for the falling birth rates in Japan. It also shows that there are periods of, just like COVID pandemic, like the episodes of Missy that you had, there are periods where there's a period of lull following these peaks. And you can see this big drop here is following the COVID-19 pandemic. Also, what very interesting to note in the cycles of KD in Japan is that for the 4 different age groups that they have followed, they have seen each age group has a different sort of seasonal cycle. For the less than 6 months, it's almost same throughout the year from January to December, except for a mild hike during July to September. And then for this age group, 6 to 24 months, it's almost same throughout the year except for a little peak in winter. And here for 24 to 36 months, it is similar to the previous one, but the dip here is a bit more sharper, and then you have a bigger peak here in January. The most complex seasonal cycle was observed for this particular group for more than 3 years, where it's all over the place really. It looks a little bit like this graph, where you have this October nadir, but then there's for a peak is there in winter, and then there are 2 more peaks in April, July time, and this could be because of the school opening times. To assess whether the seasonal cycles varied spatially across Japan, the data was actually disaggregated into prefectures. Prefecture means provinces there, and they are numbered from 1 to 47, and there's a little island there. And this is the different age groups again, less than 6, 6 to 12, 24 to 2 to 3 years, and then above 3 years. And you can see that this correlation is actually very minimal for the less than 6 months, and it's actually maximum. There's maximum correlation for the above 3-year group. And of 35 of the 47 provinces, they said there was about 95% correlation. Our colleagues in India from Chandigarh, they also reported increase in number of Kawasaki disease over the years, and they have divided them into 2 groups, under 5 and under 15. This is the under 15, below 15 and under 5. And they also showed an increase in the number of cases. And they also observed a seasonal pattern like the Japanese colleagues. And you can see here, this, they have divided it into quadrants actually for each year. And there are peaks have been noticed. So they have observed a peak in Q2 and Q4, that's October, December. And in these particular quadrants, the number of cases is 16 and 29% higher than the seasonal averages. And again, similar graphs, again, for children less than 5 and children less than 15 years, showing increase in number of cases from 1994 to January 19, and there's been an exponential increase in the number of patients. We could argue that either, the number of cases, one is actually maybe because you're more aware of the disease, or another thing is whether this could be because of overdiagnosing. So you could argue either ways. And this is a similar picture that I showed, the genetic test that I showed you the previous slides. And this particular paper, actually, they have mentioned that this particular nucleotide polymorphism here is strongly, we know that it's strongly associated with KD susceptibility, but they found out that it's not associated with IVIG resistance or coronary artery aneurysm risk. This study from Basic Sciences is actually about the role of interleukin-1 in signaling the pathogenesis of Kawasaki disease. This study was done after they injected, it was Lactobacillus casei wall extract or Candida albicans water-soluble extract. The reason why they chose Candida albicans is because they found Candida albicans in the stools of a child with Kawasaki disease. They were injected into mice, and this was followed by exponential increase in the interleukin levels, interleukin 1B, interleukin 6 and alpha, TNF alpha. And all of this increase was followed by changes in the coronary artery changes, myocarditis and aneurysms. And when they were treated with anakinra, they found that there was improvement in the vasculitis. Most of us also have started using anakinra in children who do not respond to our routine treatment of IVIG, steroids, infliximab, and so on. And currently there's a phase 3 cycle of anakinra in Kawasaki disease. This study actually identified 4 subgroups of patients with Kawasaki disease. We know that Kawasaki disease is not like a homogeneous disease, it's a heterogeneous disease, and children having varying manifestations. They studied 1,016 patients between 2002 to 2022, and they studied 14 variables, and they identified 4 distinct subgroups. So the first one was a liver group where they had liver involvement. This was the oldest age group. They had high liver enzymes, but they had the lowest risk of coronary artery aneurysm and high incidence of IVIG resistance and the lowest incidence of Kawasaki disease shock. Cluster 2 had high band neutrophils with intermediate age onset, lower incidence of cervical lymphadenopathy, high percentage of neutrophil bands, intermediate risk of coronary artery aneurysm and IVIG resistance, and the highest rate of Kawasaki disease shock rate. Then there was a cervical adenopathy group, again with intermediate age onset, highest incidence of adenopathy, higher white cell count and platelet count, and lower age Z score of hemoglobin concentration, higher ESR inflammatory markers, intermediate risk for all the 3. And the 4th subgroup with the younger age onset, very young patients obviously with very low cervical adenopathy, very high platelet counts and percentage of lymphocytes, and lower inflammatory markers. They had the highest risk of coronary artery aneurysm, as we all know, the lower age groups, and lower rate of IVIG resistance and lower rate of Kawasaki disease. Again, we know that they are heterogeneous, and we know that if we are able to identify this, then our treatment, the way we treat these patients is also going to differ, and this also provides us insights into what further research in this area could provide for us. This is a study again from PJ Chandigarh. They studied children with Kawasaki disease who had aneurysms, and they subjected them to echocardiography and CTCA, that is a low dose angiogram, and they found out that On the CTCAs, they could identify left circumflex artery aneurysms in 41 patients. And for those, they used only, if only TTE was detected, was used, then they could only detect only 1/3 of these patients. And if only echocardiography was used, thrombosis and stenosis were missed. And this is a study which shows, is asking, which they did from a Korean and a cohort from San Diego, and they looked at all the lab values, the worst Z score, and the clinical manifestations and so on. And what they said was that based on these three things, the clinical features, lab data, and echo findings, this was not sufficient to predict IVIG resistance. This was another interesting study they just came across. It's about usage of direct oral anticoagulants in patients with giant coronary artery aneurysms. We usually use warfarin and aspirin, but warfarin obviously is associated with higher risk of side effects. There is more interactions with other medicines and food, and requires more monitoring. And they tried this group. This was things like rivaroxaban and other of that sort of group. And the main problem with the studies, they were mostly adults. Only 6 had younger, were younger than 18 years at the start of this treatment, and the mean observation period was 4.9 years. 3 patients had adverse cardiac events. This is a very, very small series obviously, but even in large series they mentioned that it can fail, anticoagulation can fail in quite a number of patients. We already spoke about DADA 2. The reason why I told this was actually, this is the first time that this sort of evaluation and management of ADA2, a statement is being made for the first time. I mean, guidelines have been made, and Dr. Raju was one of the members of this group. So it addresses key questions about diagnostic testing, screening, clinical evaluation, and management of DADA 2, and it is obviously based on literature review and expert opinions. So this question was asked during the session, whether you do plasma ADA2 enzymatic activity or you do genetic sequencing. Ideally, we should do both. That is what the guideline says. And if the disease activity is normal, it rules out the condition. And again, if there's a low enzyme activity, it supports the diagnosis. When you find there are variants of unknown significance in the genetic test, the assessment of ADA2 enzyme activity is definitely recommended. Do you have to screen siblings? Yes, definitely yes. And you have to do ophthalmology evaluation and MRI for all the patients. So then there's recommendations for treatment. For the vasculitic type, you give lifelong TNF inhibitors. For acute stroke, glucocorticoid and TNF. And hematological phenotype, if it's refractory to TNF, so hematopoietic stem cell transplantation is necessary. And there may be some with immunodeficiency who may need prophylactic antibiotics and IVIG. We already have different methods to assess Takayasu arthritis disease activity, and this is a new one that I saw recently. And we know that it's difficult to measure disease activity and to measure treatment response. This is a new one which is called Takayasu Arthritis Integrated Disease Activity Index, and here clinical imaging and lab assessments were evaluated in a hierarchical manner. And this is the first type of assessment to incorporate FDG PET scan. And this is the way you do it. Actually, you have the step 1 where you evaluate the clinical symptoms and you mark if they have the clinical symptoms. And step 2, you have to check the FDG PT scan and check if there's any activity in those areas that you find on the PET CT. And you also ask for constituent symptoms and inflammatory markers. Only if both these areas are positive, then you put in 1 here. And if only one of the areas is 1, then you don't add that 1 here. Okay, and then you have a total score. The maximum total score is 17, and 0 is clinical remission, and more than 0 is active disease. Obviously, the problem with this is it'll be difficult to subject people to regular FDG PET scans to assess this sort of activity. So when I was looking about Takayasu arthritis, again came across a study about tocilizumab in patients with refractory Takayasu. And yes, they said that based on this analysis, systematic review and meta-analysis, they said that it's effective in treatment for patients with refractory TAC, and there was 1 RCT in this review. There was another one I came across similarly, but then here they compared the effectiveness of tocilizumab and TNF alpha inhibitors. And the reason why they did this meta-analysis soon after was because the ACR 2021 guidelines had recommended TNF over anti-IL-6 in refractory TAC, whereas the American Heart Association had recommended either of them for refractory TAC. And the verdict of this review was that they saw similar clinical responses, angiographic stabilization and safety profile with tocilizumab or anti-TNF. I will just go very quickly with the rest. I mean, so we have recommendations for the treatment of Takeuchi arthritis. This again about HSP IgA vasculitis. The main reason I put up this study was because there was this enzyme called APRIL that is a proliferation inducing ligand. There's a medicine that, or there's a new biologic for that can inhibit this APRIL, and this thing that can inhibit the change, or that can inhibit the B cells from changing to IgA and IgA secreting cells, which actually can later on form immune complexes and deposit in the kidney and can cause the development of nephritis in patients with IgA nephropathy or IgA vasculitis. And this was a study in adults, but I'm sure at some point you're going to take it to pediatrics as well. They showed that this inhibitor of that's sibeprenlimab that inhibits APRIL, actually in the following doses, that's 2, 4 and 8, it showed good response in adult patients with IgA nephropathy. I'll finish very quickly. This is again the role of avacopan, which has been used in adults. This used instead of steroids, is a complement 5A inhibitor, and they showed good responses in patients, in adult patients with ANCA vasculitis. And they showed that they are not inferior to steroids in week 26, and they have better response at at week 52. Something that we could consider in the future. I'll just quickly finish off these studies. So the other thing that I came across was against this study in adults about this biologic, that is a monoclonal antibody in EGPA, just these two. And I'll finish it off very quickly. So this talk will not be complete if we do not mention Dr. Debashis Danda, who's done phenomenal work in the field of vasculitis and Sjogren's syndrome in India. He was a very important person in development of Indian Takeuchi arthritis score, and his publication with 602 patients is probably the largest cohort in the world with Takeuchi arthritis. The road ahead. Mechanisms driving vasculitis are better understood. The discovery of new biomarkers, improved diagnostic techniques, novel therapeutic approaches, continued collaboration of global vasculitis community is important. And there remains much ground to cover in unraveling the intricacies. There's so much mystery around all these diseases. But anyway, the path to better patient outcomes, they seem closer than ever. So again, finishing with a Tamil proverb by Avayar, it says, "Katrathu kaimannalavu, kalladhathu ulagalavu." What you know is actually the amount of sand that you can hold in your hand, and what you don't know is the size of the earth. Thank you.
Thank you so much, sir, for such an engaging session.